Good morning and welcome to our monthly live broadcast for endovascular interventions here from Mount Sinai Hospital in New York City. I'm your moderator, Vishal Kapoor. I'm here with my partner, Dr. Raman Sharma.
Good morning.
Today, keeping a tradition of having exciting cases, some unusual cases, we have another very interesting case coming up by Dr. Krishnan and his team down in the lab. But before we go to the lab, I would like to introduce our guest moderator today, Dr. Alfio Coraccio. He's the chief of vascular surgery down at Lennox's Hospital, great supporter of our program and by EBS conference as well. So good morning, Dr. Coraccio. Welcome.
Good morning, gentlemen. Thanks for having me.
Beautiful. So it's always good to have expertise from other departments, other divisions, and of course, other hospitals as well. So thank you again for joining. So without further ado, we're going to move to the lab. And morning, Dr. Krishnan. Let's see what we have.
Well, good morning, and thank you again, Al, for joining us. I know it's you're taking time out of your schedule. It means an awful lot to us and our audience to have you and your expertise. Thanks, Raman. Thanks, Vishal. I'd like to welcome you to the lab and to just introduce our team, which without them, none of this is possible. To my right is Shalini Mani, our endovascular fellow, graduating very soon. To her right is Dr. Ajit Rao, who's the director of vascular surgery research, as well as basically part of our team, and so grateful for him to have his support and his expertise in helping us with these difficult cases. Dr. Karthik Guja, who's the director of Mount Sinai South Nassau Endovascular Services, is going to join in. He's just on his way. He's just getting ready. I can see him. Behind me is Ray Lascano. We have Alina, our nurse, Denise, our nurse, and we have Jansen, our tech, and we have a really good case. So just a preface to this case, it's interesting because, renal artery disease has come to the forefront. Our team, I was so proud, presented a live case demonstration at TIC in last Friday with Dr. Raman Sharma and Dr. Vishal Kapoor taking the lead, doing a fantastic job. The reviews were great. But with the advent of renal hypertension and the therapy of ablation, I think we're starting to get more and more atherosclerotic renal artery disease. And I can tell you our renal volume, which was almost non-existent a few years back, has actually gotten, I wouldn't say large, but definitely is more often and more prevalent that we're doing renal artery stenting. So with that being said, we decided to go ahead and explore this and see where we stand in 2025. So we went ahead and asked Dr. Rao and Dr. Coraccio to join us because of some of the complexities of this case. With that being said, as Dr. Guja, welcome. We're about to start. Shani, can you make the presentation?
Yep. Our patient today is a 68-year-old female who presented to the clinic with resistant hypertension despite adopting lifestyle modification and antihypertensive medications. Patient is currently noted to be on 4 antihypertensive medications, which includes a diuretic, and she reports to have elevated blood pressures. Her blood pressure monitoring, routine blood pressure records in home runs around 180 to 200-ish of systolic and 90 to 100-ish of diastolic. She is also intolerant to additional antihypertensive medications due to dizziness. Her past medical history is notable for dyslipidemia, diabetes, coronary artery disease, and peripheral arterial disease. In terms of antihypertensive medications, she's on 10 milligrams of Amlodipine, 320 milligrams of Diovan, and 25 milligrams of hydrochlorothiazide, and 100 milligrams TID of Hydralazine, along with Lipitor and Aspirin. The baseline blood work showed serum creatinine value of around 1.2 milligrams per deciliter. The blood urea level was around 48, and the estimated GFR was like 448 milliliters per meter square. And her hemoglobin was like 10.3 grams per deciliter. The rest of the investigations were pretty much normal. Moving on to the non-invasive renal artery duplex, which showed elevated peak systolic velocity of around 340 and 280 in the right and the left renal artery, respectively, suggestive of high-grade stenosis in both right and the left renal arteries. There's no evidence of fibromuscular dysplasia. Moving ahead to the invasive angiogram. So this is a non-selective iotogram with a pictile showing a calcified aorta and a heavily calcified left renal artery with significant stenosis. Moving to the selective right renal angiogram taken with the JR, diagnostic JR guide, following standard no-touch technique showing mild proximal right renal artery stenosis. And the selective left renal angiogram shows heavily calcified, severe proximal left renal artery stenosis. With this clinical scenario, the likely assessment is renovascular hypertension and the plan is endovascular renal artery intervention. With that clinical briefing, I'll let Dr. Krishnan to...
Yep. So why don't we stop here? We'll come back to our discussion. And so Raman, Vishal, Al, and of course Ajit. I mean, you can see here that she has quote unquote bilateral renal artery stenosis by angiography. I mean by ultrasound, and by angiography she only has unilateral. You saw the right renal artery, and Karthik, you saw the level of calcification that was there. So having said that, we felt that at this stage with our uncontrolled hypertension, likely renal artery stenting may benefit this patient. We'll go over the data that's available. But I want to talk a little bit technically. This is our current angiogram here, and I just want to show you what we have. Sorry, there we go. Yeah, so let me show you. So we got access here in the right common femoral. We just did a non-selective injection here just to make sure where we are. The catheter we have is the 7 French Boston Scientific catapult catheter, which is a renal stent guide that Dr. Patel was suggesting that we give it a shot here. We also have the steerable tour guide sheet also available just in case. And then we went ahead and just did a non-selective with a Grand Slam wire into the renal without using a no-touch technique. Obviously, we're able to wire this in. And then we did an intravascular ultrasound. So can we go on the IVUS, guys? So can you pull the IVUS up? So we did that offline so we can have some good discussion. So there's the IVUS. Can you put it on the screen for me here? Thank you. So we're going from proximal, distal to proximal. You could see extremely, extremely tight and extremely, extremely calcified. I'm going to play it one more time for the audience to show that it's not just your vanilla renal artery stenosis, and you could see why we decided to present this as a live case. So very concentrically calcified, extremely hypertensive. Can you show the hemodynamics, please, despite being on medication? She took her medications this morning. Can you show the hemodynamic screen for us? Oh, there's your measurement. There you go. Show this first. So this is her current hemodynamics while she's sedated, and you can see her blood pressure is very, very high. And then now show the measurements for us, please, so our team can see the measurements. Yep. The IVUS again.
Yeah, we can see it.
Oh, you can see it. Okay.
Yeah, but I have to see. Yeah, there's the.
There you go. That's better. So that's the what is that? The distal measurement?
Yeah. Yeah. Normal.
Yeah, that's a normal segment right there, and then it's an 87% stenosis. But can you show the reference vessel diameter for us, please? Yep. So there's your reference vessel diameter, around 7.9 to 8.4, maybe a little post-stenotic dilatation. So with that said, I'm going to just open it up for discussion, guys. Well, I mean, what do you think we should do? How do you think we should approach this, and what to do in 2025?
Yeah, I mean, this is a great case. One thing I just want to begin, with the non-invasive diagnostic testing. Can we go back to that the duplex results?
Yep. Can you go to the duplex results, guys?
I think one important thing is deciding which of these patients should you actually plan on doing the intervention on.
The slides, please. The slides.
Because we know that that there are patients who may have renal artery stenosis, but perhaps opening up the actual stenosis may not actually improve their blood pressure. And one thing that we see is that based off their resistive indices, you can kind of have a little bit more of a predictive value as far as how effective.
There you go. There you go. Oh, one more.
Yeah.
I didn't catch it on this one.
No, it's coming. It's coming. Hold on. We just had it.
Almost.
Sorry about that. It's just little technical issues. Can you go minus one slide? There you go. That's perfect. Yep. There you go.
So this is actually a very good, right? So we see that the resistive index on the left side that we're working on is 0.56. So we're kind of assuming 0.7 and greater is abnormal and maybe suggestive of some mild parenchymal disease where fixing the actual renal artery stenosis may not actually have an overall impact. Perhaps, but this is good. 0.56. I mean, I think you up front have done a very good job at doing appropriate case selection. So I think that is one of the biggest things when you have these patients to decide whether or not that they actually should be fixed in the first place.
That's
Yeah,
a
I
great
think,
point.
yeah, but I think it's very impressive. Even if you look, I know we have DSA pictures, but before the angiogram starts, the degree of calcification is phenomenal. I mean, you can see the outline of the renal arteries on both sides, and that's why this is actually a very more complex case than what it looks like. I mean, you showed the percentage stenosis and the calcification on IBUS, which is great. But these cases, like I'm sure Dr. Caraccio and Rao are going to add on to it as well, saying the complexity and how to deal with these cases, especially it's not about getting just the stent across. That is also a big deal. But what sequelae and what other procedural steps need to be done for a safer intervention, because of a lot of limitation in this case is very important. So the true nature of the aortorenal disease, which we call renal disease, more of an aortic origin, is highly exemplified in this case. I think it's a very good case to do, but important steps to learn specifically with the calcification right there.
Alfio, any thoughts?
Yeah, I just want to reemphasize what they said. It's sort of interesting. You know, Raman's question about whether it's indicated or not, you agree. It hits all the criteria. The question I always have to myself for something like that is, resistive index is low, the stenosis is bad, she's on 4 meds, obviously high pressure despite sedation and all that. So you like to help the patient. With that said, you want to not do harm. So you hope you make them better, but you certainly don't want to make them worse. And the other comment is why I bring that up. The calcification, it's aortic pathology. It extends into the lumen of the renal. So I know you mentioned post-stenotic dilatation. My question then to myself is, what's our threshold? Assuming we get, whether we pre-dilate or not, or get a stent through, what size are you looking to target? Because overinflation, as I'm sure it's happened to everyone here, with the bad calcification in the aorta, you can create an aortic problem that then is not so easy to come back from. I've seen a lot of very experienced people have a great renal result, but end up with an aortic dissection, a little perf, and all that. Certainly happened to me. So the real question is, what do we do here to potentially help a woman that looks like she needs it? It meets all the criteria for it, but not do it in a harmful way. What size are we going to do? How aggressive do you want to get?
Well, that's a great point, and that's why we've got you and Ajit here, because we know this is not a vanilla renal artery stenosis, and it's obvious that, obviously, like Raman said, we wanted to check all the boxes before we brought the patient in, because we really don't do a lot of renal artery stenting. I know you guys as surgeons do a lot of aortic work and may do renal artery stenting more often than we do as part of your aneurysmal work, but obviously those are not necessarily atherosclerotic disease in the renal, and maybe being done for other reasons. So Ajit, any thoughts? Karthik, any thoughts?
Yeah. So, I mean, I think I agree with, what everyone said. I think indications are really important here, because you'll see a lot of renal artery stenosis, but not everyone should be treated based on the trials, as we know. But this patient meets all the criteria. And then for renal stenting, I just, and even just in any intervention, it's always good to think about what can go wrong, so that way you can really be a safe, proceduralist. And so for this one, I think crossing is important. Like you mentioned, we do a lot of aortic work in healthy vessels where we're stenting the renals, but in atherosclerosis, it's like a different beast. You can perforate, you can dissect, and even crossing, you can embolize. So I think crossing technique is important, which we can talk more about, but the no-touch technique is what I prefer. And then I think in terms of the other concern is rupture. So if you rupture here, it's not like you can just seal like in an iliac where you put a covered stent in. This rupture can go into the aorta, and then you're talking about putting up an aortic stent, occlusion balloon, and you're doing it at the viscerals, which might not even be possible, by the time the patient kind of decompensates. So I think to kind of mitigate that, I think vessel prep is going to be really important here. And then I also think probably being conservative with how we size the stent and how aggressive we are with the pressures is probably the other thing I'm thinking.
Excellent points. Karthik?
Yeah, same thing. I mean, I think the biggest issue here, interventional-wise, will be for us.
Let's get this aqua shocker balloon.
Take the gradient away. How much are you reducing velocities?
Yeah. Switch with Dr. Rao.
Aggressive. Try to get your stent placement, and of course prep the vessel. Definitely much better. I know we are going with shockwave, which is probably what.
Well, that's what I want to talk to about.
Yeah.
So prepping the vessel, we're talking about, and it's already 8:20. So for the sake of time, Alfio and Ajit and I discussed this with Vishal and Raman and Karthik, and we decided to go with shockwave. Any thoughts on using vessel prep other than shockwave? Because just a little note to Ray and I, as we advanced the IVUS, it was very difficult to get the IVUS. And also, I'm not happy with the support of this guide. That's another issue that I'm worried about. I have the tour guide as backup. But what do you think, Al, in terms of shockwave for this case?
I think so. I mean, if you look at it's extrapolating, right? Because there's not data on the renals with shockwave that you could really revert to as a standard, but it's a safety profile for the periphery and the coronaries that's pretty decent. So I don't think harm will be done. I'm assuming you're using the newer platforms that's a little bit tapered more at the tip, should be able to get through pretty nicely. And what size are you picking?
It's a 4.0 coronary shockwave, Al. So you could see it's across already, right? So I'm just going to give a little dive. Put me on coronary, Karthik. And let's give a little dive for everybody. Again, the GFR is low, so we're going to minimize dye. So I think it's across, Ram, and I'm going to check with a little dye.
Yeah.
But I mean,
half.
Yeah, maybe half. But I just wanted to just make sure.
That's actually good enough. We want it hanging a little bit in the aorta so that we cover the osteum truly. So
you open up
one more.
But I think shockwave is a good use in this case. Like
I think that's fine.
No? Yeah.
Are you guys okay with that?
Bulk it.
Yeah. And
Okay.
even after the first couple cycles, you can still move it in and do it.
Yep.
Correct.
A little bit extra.
All right, let's go with the start to shock.
Yeah.
I think it'll also help it. I mean, I guess we're going to talk about the options of stenting, covered, non-covered, all the stuff. So doing shockwave in this case probably might make your life easier down the lane by delivering whatever kind of stent we decide eventually. But I think it'll give us good support. But here it looks good.
Go again.
Of it working. So hopefully it'll give us some good results.
So Alf, you're legit. I mean, you guys, I mean, obviously I have used a covered stent in the renal. I'm sure our team for bailout issues, but never for primary covered stenting. Anything that you guys can tell us about the trackability of the VBX and other things?
I want to pull back a little.
I mean, go ahead. I was just going to say.
Go ahead.
We're going to say the same thing, so you go for it.
Yeah, I was going to say, for the renals, traditionally for atherosclerotic disease, non-aortic pathology, I always stick with the 014 platform just because you're dealing with 80, 90%ers or, the real targeted population.
Go up a little higher pressure.
You have more radial force, certainly with the 035 platforms, but there's certainly a ledge there. I can't tell you many times. It sounds great to put a balloon expandable that's covered, but you have a ledge there, and if it's really calcified, sometimes it just doesn't go through. And you take what you can get. So I would like to use it. The answer would be this in this situation, certainly. But
another one.
There is a crossing profile that's potentially a problem. So we'll see. It's worth the pass. I wouldn't change wires. I'd still do it over an 014 because I'd hate to lose your wire now that you've done some instrumentation there. But I suspect it may go through smoothly because of this, but it may snag. If it snags, I would rather than keep manipulating. I would just consider using the most radial force to 014 or 018
again, and
we'll pull back.
Just so I can just make sure I heard correctly. You would opt to try to go for a balloon expandable covered stent first?
I'm in.
I would say balloon expandable covered stent. The data is not overwhelming, but I do believe it gives good radial force, and patency looks like there was a trial that ICAS put out for themselves. It wasn't really a trial, but it was more of their results.
Right.
70% at a year, or up to even 36 months, low intervention rate. So it seems reasonable. If it cannot cross, Raman, then I wouldn't get ridiculous about re-intervention to try and make it cross. I would go with the strongest profile 014 stent bear or 018 stent bear.
All right,
so I guess the question is, I guess my question for you would be, let's say we use the shockwave here. The whole idea is to, get the calcium, increase the elasticity of the vessel. The calcium, the shockwave results, the 2N angio shockwave results looks great.
Ready?
There's no to minimal dissection. Why don't we go the classic old way of putting in a balloon expandable non-covered stent?
All right, so just a question. I just want to, about you guys, great discussion. I just don't want to interrupt. I just want to tell you now we've expanded with the shockwave. Now we're going to IVUS. And in the meantime, I'm going to have our fellow who's prepared a nice talk go over what's available to really discuss, including what Dr. Karachi has said. So let's go with your talk, please. So let's go with the talk, and while we IVUS, and we'll come back with the IVUS results. What is it, 278? No, it's fine.
The PowerPoint.
Go to the PowerPoint, guys. Okay.
Yeah.
All right. No. Next. Okay.
A little background on atherosclerotic renal artery stenosis and renal artery stenting.
Loudly, please.
Okay. Atherosclerotic renal artery stenosis is a common cause of secondary hypertension leading to resistant hypertension cardiac destabilization syndrome, and progressive worsening of renal function. That being said, the randomized control trials in renal artery stenting have shown no difference in clinical outcomes when medical therapy alone compared with medical therapy with renal artery stenting. Why? Because these trials have not enrolled patients with severe renal artery disease who would likely to benefit from the procedure. And to start with the STAR trial and how and why did these stenting trials go wrong. So STAR trial is a multi-center randomized control trial which enrolled around 140 patients. So the major setback of this early STAR trial is that there's a major problem with the enrollment criteria. The enrollment criteria for this trial is based on a non-invasive assessment like ultrasound, and there was like absence of core lab assessment of stenosis increased the chance of enrollment of patient with insignificant disease into the trial criteria. And 1/3 of the trial criteria patients had like 50 to 70% of stenosis. It follows that a large proportion of patient enrolled in STAR trial had insignificant disease, and it is expected that any intervention will not lead to a clinical improvement in this subset of patients, and hence the study is underpowered to provide a definitive estimate of efficacy in terms of primary endpoint. Moving on to the second trial, the Astral trial, which is a multi-center randomized controlled trial which enrolled around 800 patients, and the modality used to assess the severity of stenosis again here is ultrasound. In contrast to other trials, the patients were enrolled only if the physician was uncertain if they would benefit from the intervention. Thus, patient with high-grade stenosis who are likely to benefit from revascularization were excluded outright from the trial criteria, and only 20% of the trial criteria had anatomically significant renal artery stenosis. And considering both the STAR and Astral trials, the operators had a lower technical success rate than expected, and the post-procedural complication rates in both STAR and Astral were like higher as compared to other published data, and the use of embolic protection devices was lesser in both of these trials. And the third largest randomized trial, which is the CORAL, which enrolled around 950 patients. So the enrollment criteria for CORAL trial is renal artery stenosis with angiographic stenosis of more than 60%, and the systolic blood pressure criteria was more than 155, and who are on 2 antihypertensive medications. So the major limitation of this CORAL trial is the patients were not optimized with antihypertensive medications, and most of the included patients had mild stenosis, and the stenosis assessment was again based on non-invasive assessment and angiographic assessment of the stenosis. So this being discussed, moving on to the SKY consensus and ACC-AHA guidelines on hemodynamic criteria for a significant renal artery stenosis, which includes an angiographic stenosis of more than 70% and an IVUS stenosis of more than 70%. And in case of stenosis between 50 to 70%, they need a physiological assessment of gradients with a peak gradient of more than 20 and a mean gradient of more than 10, and with an FFR of less than 0.8. So this signifies the hemodynamic criteria for a significant renal artery stenosis. With that being said, the class 1 indication for renal revascularization is patients with significant renal artery stenosis and who have a acute flash pulmonary and who presented with acute flash pulmonary edema or acute heart failures is a class 1 indication to revascularize, and the class 2A indications are patients who present with unstable angina and patients who have significant renal artery stenosis with resistant hypertension or with hypertension who are intolerant to additional antihypertensives, and hypertension patients with an unexplained unilateral small kidney. These are all like class 2A indications, and progressive CKD with bilateral renal artery stenosis or renal artery stenosis in a solitary functioning kidney. And So the resistant hypertension and a special criteria of resistant hypertensive patients who are on maximally tolerated antihypertensive medications with unilateral renal artery stenosis is a class 2A recommendation for revascularization. Summarizing that, moving on to the recent 2024 Artisan trial, which studied the safety and efficacy of cover stent and de novo renal artery stenosis. This is an open-labeled multi-center trial which enrolled around 130 patients, and the enrollment criteria is renal stenosis of more than 80% angiographically and a blood pressure target of more than 155 on at least 3 antihypertensive medications. And at the end of 36 months, the primary patency was around like 70%, and there was a significant reduction in systolic blood pressure in this subset of patients selected in the Artisan trial. So to summarize, the best strategy to approach the treatment of atherosclerotic renal artery stenosis is to choose the ideal patient who would likely benefit from the revascularization strategy and to optimize the safety and long-term durability of these interventions.
Excellent presentation. Really, really good. So guys, I mean, before we get to the discussion, I want to show you the angiogram. You saw the angiogram. Let's go to the IVUS. So the plot thickens, as they say. So here's the IVUS.
The vessel is ginormous.
Yeah.
Oh,
well, I guess me and Raman were talking about how much dog boning was there when they're doing the shockwave. Yeah. So dissection right there. Yeah.
Where is that? How far from the?
That's very close to the ostium. Yeah, close to the ostium.
I mean, you can see some luminal gain. I mean, of course, not as impressive because, like we said, it's on the third treatment. Was there a little bit more expansion of the balloon?
But the dissection starts from that branch. Right from that branch, so it goes into that aneurysmal segment.
And this has to be covered. Yeah.
So
the question now is, I mean, listen, do you now further vessel prep with a 6.0 Viatrac to further expand this, or do you go with a stent, or do you go with a covered stent? I mean, you saw the data that she presented. Obviously, the renal stent trials, were not performed probably optimally because, as you know, with these with the percent stenosis that was enrolled, the lack of we didn't talk about distal protection here, but the lack of dedicated distal protection devices were also an issue. So we don't really have any guidance from that. But in this particular case, in ACCHA, she's falling into a 2B because it's unilateral by angiography, bilateral by ultrasound. However, uncontrolled hypertension. But the one category we never discussed is unilateral renal artery stenosis with bilateral nephrosclerosis, which again could act like bilateral renal artery stenosis. So I think that's where she kind of fits in. So I'm not worried about the indication. Now I'm worried about technical. I mean, what do you guys think? I need your advice here. We all do. Alfia, what do you think?
Yeah, I mean, I think based on that last trial, I think the results with covered are acceptable. I don't necessarily think it's proven that they're better. With that said, or is it good radial force with those balloon expandable stents? Yes. Is it better than an 014 platform, 018 platform? Probably. But with that flap that you have there, the calcium that you're seeing on the angio, I would try a smooth pass with a covered stent. If it does not pass, I would not get greedy. I'd pull out and drop down to an 014 stent. That I learned this from you guys. Just really calcified left mains and LADs. Some of those can be taken up to a size which is acceptable, has good radial force, and stick with an 014 and just get out.
Yep, but the question is, would you predilate this further with the 6.0 Viatrac?
Yeah, I heard what you said. I don't think so. I don't think so.
Kind of interesting. Yourself,
when you say you don't have a filter there, every little manipulation microembolizes. If you really believe in filters for the renals, I know at the time there's all these discussions about identifying microemboli, and that's why filters should be used in every renal case and such. So I do believe there's emboli there. So the less manipulation,
just to make sure it wires.
Preserve nephrons, then. Yeah, I guess either use a filter or do the least manipulation possible. I mean, you're doing no-touch techniques for a variety of reasons, not emboli necessarily. So I think what you could do to protect it best is best.
Well, I mean, the good point to note, I guess, is you see the dissection flap is in that so-called larger segment. You use a 4.0. The large segment is almost like a 6.0 vessel, 6.0. but the dissection is actually extending into the post-stenotic lesion, which is very interesting. I would have expected more at the lesion itself, but it's actually going into the stenotic segment, which is actually the bigger size than a 4-row shockwave. So it's interesting how technically the dissection, I wouldn't say propagated in a way, but there's definitely an extension of it from the tightest lesion spot towards the stenotic segment. So something interesting that happened with the shockwave, which you are not expecting. This is what shockwave claims to say is our dissection rate is based on their 77% less on PADs, not renal, but generally lower extremity based on their disturbed PAD trial. So see.
So I went to this is an important point. I mean, at what Vishal and Raman and what Karthik did about the dissection. So we went to a different view to elongate it, and you can see with the elongated, the dissection is not propagating into the branches. Yeah. So it's proximal. You can see the dual shadow at the ostium. Al, I worried that, the IVUS, Ajit, what I were watching as the IVUS went through, it was very tight. Yeah. I worry that there's no way a covered stent is making this. I mean, there's no way. And that is nothing against VBX. I think it's the best stent on the market along with the other covered stents. But the point is that, this is not something that's really going to track without an 035 system. So, Ajit, I know you talked about switching out for an 035 wire. You want to talk a little bit about that?
Yeah, no, I agree with you. I mean, the IVUS barely tracks. So VBX over 014 wire is definitely not going to track. Yeah. I'm not even sure the 014, the Herculink or whatever we use is going to track, to be honest. So I'm worried about that.
So the question is, would you change out for an 035 wire?
I just to say, I think I would try the Herculink first, and then if that doesn't track, we have to switch out to 035, and then
regardless.
Yeah.
I mean, the only concern here with Herculink is how much can we dilate the Herculink? How confidently can we dilate the Herculink? Alfio's point is very well taken. Is if you have a covered stent, you have a liberty to expand it as much as you can. I mean, at least even if you have to tear the ostium, you can. Now it's a covered stent; it's covered. You can change it to an 018 over this wire. You can put an 018 Trailblazer or something and change it to an 018 wire and try it. If it doesn't cross, we always have an option to go back to Herculink.
Okay.
But I think when we put the Herculink, my main problem thought process is that ostium going to expand?
Well, that's why I want to pre-dilate with the 6. Raman, you were saying?
Yeah, I would pre-dilate for sure. I mean, I think that's just coming from like a lot of like a use of the IVL in the coronaries. Even in like osteo left mains where you kind of have to clinch while you're going up with the IVL balloon at the osteo left main, you still want to pre-dilate before the stent.
I agree.
Give us
there's another option, PK, you can try. I mean, if you take it's a viable option. Is you can actually.
So is a good idea.
No. Okay.
Yeah. What you can do is actually do a wire again. Use the 2 014s as one system, and then track the 035 balloon over the 2 014 on over.
What I'm worried is
the only thing is that dissection. If you're confident enough that you will not be there. Then you don't have to do an 035 system. You can do double 014 wires and just track it over it. System.
We're all good, but I think that's. I mean, look, I think for me personally, Ajit and I saw the difficulty in Karthik of advancing this IVUS. Let's try with a Herculink. And like Alfio said, we have to talk about when we're going to say enough's enough and with our endpoint. The problem, Al, is with renal artery stenosis, overdilatation is perforation, underdilatation is high restenosis. So the idea would be is we have IVUS. I think we secure this dissection plane. Let's give another 1,000 of heparin, please. We'll secure this dissection plane, and then if we need to post-dilate, we'll post-dilate. But I think judiciously, we can check a gradient across the renal once we've secured the dissection plane with the catheter. I mean, does that sound like a reasonable idea?
It does, but may I complicate things just further? Let me ask you a question. What is your end targeted size that you're hoping to achieve?
Yeah. Well, I was thinking about a 6'5". 6'5" is because I was thinking about 6'5" because our distal renal is about a 7'5" or so. We can go with the 6'0", which is fine as well. But it'll be floating in the breeze in the distal. So that's one of the worries I had.
So we have to end it here.
Again, I'm open to the suggestion. Obviously, it's a very difficult case.
Honestly, this is my opinion. I think it's a little greedy. I would probably be happy with a 5, taking a 5.5 if you can, just overinflated, or 5 1/4, just because it may be a patency issue, but it's a lot easier to deal with than an injury issue at this point. That's my opinion. Again,
no.
That's why. Happy, you'll come back in a month and it'd be narrowed and probably regret it. And then the next question would be, if you are content with a 5 and change, what's the largest profile you can achieve with a drug-coated stent that you guys use in the coronaries and the left mains and things like that? And is that enough radial force that you would treat it similarly?
That's
well, I think radial force wise we're probably okay with the coronary DES. We have a 5.0 Medtronic DES in the shelf. I think we have one here, but so we could try that. We could use a drug-eluting stent. But I think the mechanism of failure here, Al, is going to be recoil. I don't think it's going to be atherosclerotic. I mean, interval hyperplasia. So I think recoil is the major issue I'm concerned with. So with the Herculink, you know, the patencies are phenomenal, as you know, in the Brevismo's trial and so on and so forth in a very difficult renal stenosis. So I'm just trying to think, not Brevismo, what am I talking about? The Herculink study. So what I'm thinking is at this stage, why don't we split the difference and go with a 6, and we can post dilate it with a 7 if we need to. Is that okay? I mean, I know there are different opinions. Raman, Vishal, what do you think?
6.0 is our maximum limit for both of us to stretch that stent to. Post dilate, no.
PK, I'm kind of with your original numbers.
This is a
maybe it's just the aggressiveness in me. But 6.5 sounds
too much.
No, sounds good.
Sounds good.
Yeah. No, for me, 6.0 is. 18. I'll take 6.0. If you get 6.0 in, good dilatation, we're good.
You know,
what size was the shockwave?
You know, the
shockwave was 12, right?
You know, sometimes what I found myself doing is that if these stents don't really make their way easy, you can kind of boomerang
we need 18.
Right, 18 and what?
You can bend them in the middle to kind of help them take the
18 is
turn.
fine.
You have to go to that branch, right? So you need 18.
I think there is a...
No, I don't want to go into the branch.
No, right before the branch you have to end it, because the dissection starts right before the branch.
We change the guide system to kind of give us better trackability. I mean, there are still room. I do agree that we have to agree on what our set destination therapy is going to be. But I think we have some other provisional steps that we can do to ensure that we can actually reach our destination therapy of choice.
So I guess the biggest limiting factor here is, you know how technically when the calcified lesion, we actually take the sheath across the lesion and then we unsheath the stent, especially covered stents, so that they don't fall off their balloon. In this case, you don't want to try to be that aggressive because the chances of embolization and causing renal injury, especially the parenchymal injury, is higher. Otherwise, that would have been a good option. Once you're ballooning, you just track your sheath up and then you unsheath it. But in this case, it's too risky. Having a dissection and calcification at the same time, it can cause more trauma and more trouble in the renals than doing it.
Well,
that's the biggest issue.
Those are good points, Ajit.
Yeah, I was gonna say, if you look at the calcification, it goes into the aorta. Yeah. So that's like, even with a covered stent, there's no guarantee you're gonna seal. You know what I mean? If you're being aggressive. So.
Oh yeah, push.
It's going.
Right, positive.
I'll let you control
a little bit more.
I'll let go of the wire.
Yeah, that's why I wanted to pre-dilate.
No.
You didn't give a little bend to the stent, did you?
No, I didn't.
No, I mean, because that can kind of help it to take its turn.
No question.
You're good. Make a little boomerang.
Yeah, well, I think we're in now. Okay, deep breath worked. All right, ready? That was my deep breath, not the patient's attached test.
Good.
All right,
sure.
You're gonna puff it out, PK, to see what the lead is?
100%, Al. 100%. I barely jimmied it in, so I don't want to go crazy. Let's just check here. Oh no, off DSA. So I don't want to use DSA here because she's not going to cooperate. And you know, I think it's a little long.
So what size? This is what 6.0.
This is 6.018.
Ooh, wow.
That's a good spot.
Actually, that's farther in than I thought.
Yeah, I was surprised too.
That's a good spot. A little bit more in, probably.
I think.
I mean, I'm going to go to another view here.
Yeah.
Go tiny bit.
Distally, we're definitely fine. Approximately, you always want to be a couple millimeters outside, right, of the origin. So that's what we got to make sure.
That's actually good.
Want to go quaddle a little bit?
Okay, ready?
Well, that's good.
That's good.
I would pull it back a little bit.
I would almost pull it back.
Look at a
tiny
bit.
I agree. It's got to come out. It's got to come back, right, Al?
Yeah, tiny bit.
Yeah, just like
one there. The stent is right there.
That's good.
Right.
That's good.
I'm impressed that it went through.
Ready?
Yeah.
Inject. I'll take it.
Yeah.
What do you guys think? Al?
Yep.
All right, let's go up. All right, go.
He's going to jump in.
11.
He's going to jump in, PK.
Don't worry, I'm straightening
it. He's going to push the guide.
Yeah.
There we go.
Go to 11.
Actually, it became coaxial. Wow, nice.
I pushed it up.
Yeah, good.
You went to 11?
I went to 10.
Go to 12, please. There you go. 12. Okay, excellent. Good. Down.
Is she feeling it?
Nothing.
No.
Okay, so now hopefully, let's see. Now let me just walk this back a little bit. It's always sticky, you know that.
Now it gets right closer to it.
Okay, go up now.
I'm going to 16.
No. 12. 12. Okay, down. Okay.
Nice. At least the expansion of the balloon looks good.
Yeah.
We were concerned about
very
that
good.
small area right at the
nugget.
ostium. Yeah.
And you went with the 6.0?
6.0, yeah, 6.0.
Well, the shockwave balloon opened up. I think it was just recoil when we did the angio after.
Yeah, no, that was true.
Which is always a good sign.
All right.
Take the recoil better than an under.
I am surprised that the Herculean went in, though. You know, which is good. I mean, it's
good surprise.
I just want to keep the balloon in. A little picture, guys.
Wow.
Looks good.
Okay. The question is now we need to IVUS it, and then looks like we have to post-dilate it. Like there's something going on at the end of the stent.
Yeah,
Let's see.
definitely need IVUS.
We'll figure it out. We'll rail this, please.
Dissection plane, that's what I'm saying.
It just may not. I may not be engaged properly. You checking ACT, guys?
I mean, there was
The dissection goes to the big branch. The dissection, right? According to the IVUS, that's what I was trying to say. Starts right at that big branch. So we have 3 more millimeters of dissection plane.
Yeah,
That's why it's
but
hazy.
it doesn't look flow limiting, guys.
Yeah, it's
that's
not
what I'm
flow
gonna
limiting.
say. It's just the aneurysmal segment right there.
The
so
question is, how
don't
does it
be
look on
overexcited.
IVUS? That's the only question.
Well, I remember these cases IVUS, which
I mean,
unfortunately worse
this
than
is a
what it
case
is.
where if you know, even if you just take like a pressure wire across, even if you don't want to do any hyperemic response,
Right.
and all you see is a like a negligible gradient. I mean, this is an excellent result. You went from a 0.5 millimeter vessel to a 6 millimeter vessel, and you haven't even post-dilated, should you even want to.
I would definitely.
And I agree with
so
Raman completely. You got a great result. You know, this is one thing when people say about IVUS. You know, it say it doesn't look great on IVUS.
Overreads.
Okay, but you're going to chase after the branch and start manipulating downstream when there's no fluidization. You got from 0.5 to 6. I don't know. I would walk unless you have a significant gradient there. Or
There's your
something.
plaque. There's your plaque.
Oh, we can't see the IVUS. Hold on. Can we put on the IVUS on the screen, please? Instead of the
So
hemodynamics?
I'm into that top
Yes.
branch now. Now I'm pulling back. Ready?
Yeah, ready. It's just
Oh, I don't know if that's plaque. I don't know what that is. Here's our stent.
it's right at the edge of the stent. That's where we see it too.
It's like a small hematoma, which won't be.
I'd leave that PK.
Yeah, let's take a look here. We'll take a better picture. Give me a fix this. Now we take a look here.
You want to take a diagnostic catheter and engage it?
To the point that was made, maybe if one of these little pressure wires, if you want to put it in there, if there's no gradient, I'd walk.
That may just be the
diagnostic
distal
catheter
edge of
and engage it?
the
A 4 French
flap that's
catheter?
like has a little hematoma in there. I mean, 'cause
Little
looks,
thrombotic,
you
yeah.
see the actual flap here.
Okay, I'm now correct. So.
It is a flash.
Ready for DSA?
behind it.
It's just the flap
DSA,
we
guys?
saw originally.
Correct.
Okay,
It just has a
my dear,
thrombus behind it now.
Yeah. Maybe just,
don't hold your breath for me. Hold your breath. Hold your breath. Ready? Ready, guys?
Look at the angio,
what
please.
are we doing here?
No, the day in angio. Thing.
While we do all this, we have a couple questions from our live viewers. This is a nice one.
Looks better on the angio than the IVUS.
Go ahead.
Could this be done via radial axis? I'm going to say yes. But there are a few limitations with that. Obviously, the one of the issues would be the working lengths of the devices that we have.
BK, what happened to the ostium of the stent?
We would still be able to go down with the
ostium
shockwave
of the
from the
stent.
radial.
No, nothing happened to the ostium stent.
Would you just,
What
what about,
you may,
I'm not in the
depending on the
ostium,
height
huh?
of the patient,
What about
actually
just
end up having to
post-dilating it with
use
a 6 balloon?
the peripheral
Just a
or
stent?
extremity
No, just like a balloon.
Because
I don't-
distal part?
yeah, the tack down
may
the
then
dissection
change
or whatever
the
that
overall,
is. Because
the,
tracking a stent
system
through
you're
that
gonna
stent
be
might
working
it
with,
might
but
catch,
yes, it could be done. And then IVL versus cutting balloon for renal artery.
All right, give me the 6 Vitrac. Now let's post-dilate.
What do you think?
No, I think so. Most of the times you're right. I mean, radial, it can definitely be done through the
doesn't look
radial
bad on angio.
because unless you're a very tall person, most of the devices, standard devices, especially in the radial, can reach there, including the shockwave as well. So I don't think it should be a big issue unless there are some, short lady spasm. I think those are the more technical limitations in those cases. But from a intervention perspective, we have selected guides and wires and done intervention at the radial. Sometimes more favorable. In this case, the groin worked fine. Sometimes the takeoff is such off that radial actually is more favorable than the groin.
Put me on corner
So
again.
in this case, it's equivocal. Regarding the cutting balloon and the shockwave, you saw, like this case, I know it's retrospective, shockwave caused dissection, cutting balloon, the chance of having dissection and having more issues are higher. Deliverability becomes the biggest issue, I think, based on the degree of stenosis. And then the amount of so-called controlled dissection we have with the cutting balloon probably will be higher than shockwave, like how Alfie was talking about. Shockwave's claim to fame is decreased dissection. So I think if feasible, doable, shockwave will be my to-go balloon or pre-treatment balloon to the definitive therapy.
And go here.
You want to go a little bit more?
Cutting balloon.
Right there?
Yeah.
Right there?
Maybe that's good. What do you guys think about that? We're going to post-dilate the stent in that area that's a little narrow.
Like tack it up?
Proximal side, yes, because the undersurface looks like it's getting pushed up a little bit, but distal, I wouldn't mess with it.
Yeah, you're outside of the stent.
Branch.
I just don't like that haziness, Al.
So I was showed a little bit of thrombus behind that dissection plane.
Yeah, I think
we can wait. And
Ibis were absolutely correct. I think that original dissection plane did extend beyond the length of the stent. Yeah. I think what we're seeing is not any tooth spacing of plaque, but just the actual flap that is now
organized.
Go up to 4
behind the actual flap.
Correct.
That does not look like toothpaste plaque.
Right. Because like you saw in the others, there was not real plaque right there. It was just merely the dissection for shockwave. So pre and post run.
Save that.
Now this is where it gets interesting. It's, you were able to create a dissection with a low pressure 4.0 shockwave, and now we're going with what looks like a 6 or 7 millimeter Herculink. What size of balloon?
This is just a 6.0 balloon.
6.0. He's just dilating the stent right now.
No, I'm just trying to tack up the distal. Get down.
Cover it. Now the question is, how easily are we going to be able to have another dissection, another balloon expansion?
That's a very good point.
Renal vessels are very, very friable.
Exactly.
Very easy to create, issues.
Especially in the patient's case.
Question: should protocol include only a pre-IVUS and no post-IVUS?
I mean, like I said, the good thing about IVUS is you see a lot of things. The bad thing about IVUS is you see a lot of things. So it's hard to say.
It's hard to sell IVUS that can only be used once.
I know Alfio doesn't look happy at all because that tacking of the disc. I know. I can see he's quiet. He's like fighting an uphill battle. But I think you're right, Alfio. Oh, let me give you an option. What about an alternative of, I don't know, it's just a random. Wait for 10 minutes, see how it does. I know it's a random number. I know, but what I'm seeming to say is like, what happens to this plane? How does it behave one way or the other? I know there's like an arbitrary minutes added to it. Would you do that before you start ballooning all this off? What's your strategy? Or just leave it?
I would. I'd give it some. I'd give it
Looks
some time.
Even better.
And again,
I think so.
Changes because like it was just said. We got it with a 4 balloon. To start putting 6 balloons by a branch point.
But I don't know if you guys see it now. It looks a little bit better. We could put a 5.0 coronary stent, a short one, 5.08 right there, and tack it. It'll definitely track.
No.
Wait, I'm sorry. Where
wants to extend
where are we talking about it? Into one of the branches or
in the distal area? We start at that the first branch, the first large branch. Based on the first IVUS, that's where actually the dissection plane starts.
I think this time I agree
right
with
after
Alfio.
that first branch.
Leave it. Now I will leave it.
Now it looks better. There's no question.
Yeah.
Play it,
so I think.
So we're going to play one more time. So this is a very difficult decision, guys, because when we have her on the table before she thromboses, it's better to take care of this rather than leave it. But here the flow looks good. Let's do a DSA.
Is this the pre or
post?
Do you show the pre?
Show the pre.
Right there.
Yeah, this is pre. You can see it's more hazy.
Pre is more worse. Oh, that's after the stent. Now they're deploying. Yeah.
No, that's before the balloon.
Yeah, they're before the balloon.
And then play the new one again.
The new one's a lot better. Yeah. Play that.
I think a DSA will help too.
Let's do a DSA.
If we can get a good picture.
Ready?
Still a little hazy. But no.
Yeah.
I think we leave it.
Yeah.
Leave it.
Everybody agrees?
Yeah.
I agree.
What do you think, Al?
No more.
Yeah, I would leave it.
Must.
No more.
I mean, I could,
You know what,
we
just before you leave the room, shoot a picture with the wire out, because that's really more critical. Make sure you're not tacking it up with the
Oh,
wire
there's no
or
question.
something.
No, we're gonna shoot a paper. So give me a JR catheter now. I'm gonna go into the stent with a JR.
Give me a 4 French.
We have it. So we're gonna go into the stent with a JR. I'm gonna shoot a picture. We post dilated. It looks good, and we'll take a picture of the JR within the stent.
5 PK or 4? Take a 4, no?
We have whatever. It doesn't matter. We're 707.
Well, the good thing is the ostium looks well expanded. The nodule or the hump or the nugget, whatever you call it, is actually gone. So that's a good sign that the Herculing the vessel did respond well to Herculing and the post-dilatation part. So I think that's essential part. And there is no real trauma. And like Alfie was talking about, dissections extending from the ostium up and down the aorta is not there. So I think those are good positive points with this. With the stenting and the results here. I mean, distally, like you said, it happened.
I mean, the problem, Alfio, Jet, I mean, the whole team watch the wire, is that, we have no data here to suggest one or the other. I mean, do we leave this dissection? We know in the coronary, we definitely wouldn't leave it, at the edge of a stent. Here, it's a larger vessel. Put me on coronary, guys. Here, it's a larger vessel, obviously.
I mean, I think the renal can tolerate a good degree of stenosis, and certainly it's way better than what we started with, so. Yeah. That's why I think I would definitely leave it alone.
Counteract and then go back, and I think you're hitting the bottom of the stent.
It's just catching.
Yeah, I think to speak to this point, the dissection in a coronary will result in an MI. And this patient has tolerated, if for sake of argument, almost a dissection-related stenosis. So even though we all agree there's no dissection-related stenosis, she has tolerated this successfully. Physiologically, hemodynamically, her renal function preserved. She has symmetrically sized kidneys. Her resistive index is still
wake her up,
reasonable. She's on 4 medications with poorly controlled hypertension, but still,
hold your breath.
She's, not having flash pulmonary edema.
No. DSA, please.
So I think, to speak to that point, I mean, I think she can tolerate.
Correct.
A little dissection. The renals can.
Yeah, but from a technical perspective, I think it's.
I think we're okay,
that looks
guys.
Really good.
What is that?
Oh.
Is that dissection? That's the dissection.
Yeah. What do you think?
I think probably because we tacked it down proximally, but it's filling in distally.
In the inferior part, Is it still hanging?
Yeah.
Yeah, so it's gone.
It's gone. It washes out.
It just fills late.
That's what I'm saying. It washes out too. So that's also a good thing to say that, okay, it is there. We know that. The question is how far we go after it.
Yeah.
I think the lower branch is also filling, which is what you think might be more compromised. The upper is a huge lumen, so that's going fine. The lower branch is still there.
I think it's just filling distally. And I think even if we put in a stent, which we can only use uncovered now so we don't compromise a branch, it's still going to fill.
DSA?
So I would probably
Correct. It's on DSA.
Most likely it's going to fill, so I would just leave it. And the lumen looks really good, actually, so
I think the
stenosis is resolved.
Yes, definitely.
What do you guys think?
Yeah, I mean, I'd
leave it. There's no flow restriction. There's no hang up. Hangs up for a couple seconds, leaves. It's not going to thrombose, BK. It won't.
All right.
And it clears out, see?
All right.
All right, well, we're done. And so, like I said, this is I was telling everybody, I mean, it's not a vanilla renal stent, and obviously it's not, as you can see by the amount of discussion and the difficulties we had in this procedure. I like Roman's point of IVUS pre only, not post. Sometimes you don't want to.
It's a new Philips marketing strategy.
The stock went down.
One use only, disposable IVUS.
So let's talk a little bit about follow-up on this patient, guys. I mean, okay, now you've had I wouldn't say suboptimal result, but maybe not the perfect result in terms of our kidney, the finished product here. A little bit of a dissection. How would you guys follow this patient, and what's the role of antiplatelet therapy? Would you add antithrombotic therapy on top of antiplatelet therapy?
I mean, I just wanted to just start by saying this is not an okay result. This is a perfect result that we had begun the case to hope to achieve.
That's true.
We had a stenosis. We have achieved the exact result that we want without creating a major complication that we had already outlined beforehand. So, I mean, I would walk away with this case very, very satisfied.
Yeah, I think that's right. I mean, it's a great result. good flow. You achieved excellent stent deliverability and post-stent. There's no residual stenosis in the stent itself.
Yeah.
I think that's the biggest founder. Like you say, it's all about the residual stenosis and the ISR that kills in these cases. Though here it's very well expanded. So I don't think you should have any issues down the lane. That healing of the dissection will happen. We have experience in the past where these dissection planes heal and they still maintain their good outflow, so to say. So I don't think that's going to affect any of the future outcome or decrease the chances of stenosis in this patient. I mean, the patient will do well as if anybody else patient was done. So, but based on your question, I guess we'll start with Alfio first. Alfio, your recommendations post-procedure?
Yeah, same. I think you did a fantastic job. We start talking about data. There's no data in terms of putting stents at the branch points and all that kind of thing. So it's not flow limiting. Minimal one antiplatelet, or probably do two in terms of anticoagulant. I don't think it's necessary.
Correct.
There's data. It's not the same thing, but when we look at dissections, carotids, and all that, which the consequences are high, it was studied anticoagulation versus dual antiplatelet, no difference, same result in terms of risk of stroke. It is extrapolating to the renal parenchyma, but the tolerance to the kidney is much better than the head. So we dual antiplatelet dissections in the viscerals and carotids all the time. I don't think you need anticoagulant.
Yeah,
Jit?
Agree.
Yeah, I agree. I would do probably dual antiplatelet therapy for this for like a month. I don't think patient needs anticoagulation, and almost not do it because of that dissection flap, because I kind of wanted to, hematoma, I wanted to thrombose, and then close follow-up.
Arthur?
Aspirin Plavix, but I think the biggest issue here will be for us to do a follow-up ultrasound very quickly. Normally I do it in 3 months, but for this patient I would probably do it within a month.
Within a month.
Just to make sure what the dissection plane, just to see how the ostium, is there a recoil, what's happening with the velocities, how is our resistance index has changed, how are the velocities changed.
So Al, with Najit and even all of our team, I mean, would you guys get it before discharge? I mean, would you get like a baseline?
I agree with it. Yeah, I agree with everything he said. I would even do it if the quality of the ultrasound inpatient, because it's tech dependent, but if you have good techs in house, I absolutely would do it before. Because if you did see stagnant flow or anything else, then you would consider an anticoagulant. But if you could do it before they leave, I would do that.
Yeah, that's what I'm going to do.
All the reasons that we just mentioned.
Okay, fantastic. Awesome. Well, listen, guys, it's 9 o'clock, and I want to thank just on a personal level, Alfio, for taking the time for being here. Thank you very, very much. I mean, your input was great, and Ajit, as always, thank you, brother. Thank you very much. And Raman, Vishal, you guys can sign off, man, and thanks again.
All righty. Well, guys, this was a fantastic case. Thank you all for joining us with another enthusiastic and challenging case here from Mount Sinai. And we look forward to having you join us again next month on the last Wednesday of May, on May 28th, for our subsequent live broadcast here at the Mount Sinai Fuso Heart Hospital. Take care and have a great day.
Have a good day.
Next month.
Take care.